right? So as we know, obesity is India's hidden epidemic. So I'm very surprised to know that there are more obese women than obese men. So 31% of women are statistically obese compared to 25% of men. And as we go through our discussion, we'll see how my talk for today's discussion is the impact of obesity from menarche to menopause. So we'll be discussing various case scenarios. So obesity is something talked about day in and day out these days. And more than 230 complications which have been associated with obesity, and it has repercussions in terms of CV morbidity and mortality in future. So we have connections with almost all systems of the body, particularly of interest to gynecologists. We might say maybe infertility, subfertility, PCO, pregnancy-related complications, and menstrual irregularities. Of course, there is a wide spectrum. We can have type 2 diabetes and various cancers as well as a part of the related complications. So, of particular interest to gynecologists, will divide into different age groups. In the menarchal age group, we can have early menarche. In the reproductive, we can have PCOS, subfertility or infertility. In the pregnancy-related age group, during the pregnancy, obese females are more prone to develop preeclampsia, gestational diabetes, and increased risk of cesarean delivery as well as miscarriages. And in the later age group, in the perimenopausal period, there has been a lot of discussion surrounding mechanical effects of obesity. So few of them being stress, urinary incontinence. I am very sure most of our gynec friends are encountering day in and day out, as well as hot flushes. And lastly, for post-menopausal later elderly males, there is a possibility of functional decline as well as increase in risk of cancer, endometrial cancer. So a very common question asked to us, that is obesity only a result of voluntary excessive energy intake and decreased energy expenditure? કે સાહેબ હું બહુ ખાઉં છું અને એક્સરસાઇઝ નથી કરતો માટે જ મને ઓબેસિટી થાય છે? So the answer is no. Obesity has so many factors at play. There is almost 40 to 70% in role of genetics. Your biology is very, very complicated, and there is multiple pathways. There are multiple pathways will lead to obesity. So obesity is not just about simple excess intake or lack of exercise. There are various factors, various hormonal factors, various environmental and genetic factors at play. And hence, obesity from now on has been recognized as a disease. It is not just excess of fat deposition. Various societies throughout the world recognized officially obesity as a chronic endocrine disorder, and it requires a proper intervention in terms of various strategies. So adipose tissue is now recognized as an endocrine organ. It does have its repercussions in various other organ systems of the body. Of particular interest for today's discussion, there is action on the visceral fat, there is action on the pancreas, both driving an insulin resistance in the body, leading to various complications in terms of metabolic syndromes. So in case of gynecological dysfunction, various underlying factors at play while causing obesity-related gynecological dysfunction are adipokine dysregulation, adiponectin secretion, hyperestrogenism, leptin secretion, less aromatase-related complications. We'll be discussing this one by one. And the insulin resistance, which is caused by the obesity, has also various gynecological repercussions in terms of hyperinsulinemia and androgen production leading to PCOS, estrogen production and progesterone resistance leading to endometrial cancer, and endometrial receptivity defects and transcriptome alterations leading to infertility. So these are the various common gynecological patients which I'm very sure all of you encounter: PCO, endometrial cancer, and infertility. So just before we go on to the cases, I want to highlight few differences in terms of obesity measure might be different in terms of Indians or Asians. The WHO defined overweight or obesity cutoff is 30 kg per meter square BMI. However, for Asians and Indians, that is bit lower, that is 25. So most of us sitting in this room would classify as obese. Secondly, there are various parameters for measuring obesity. So BMI being one of the most commonly used, but it is not the only parameter we use for classifying as obese. People with normal BMI may also be obese. They may be classified as obese based on various other parameters. Other parameters being waist circumference, waist to hip ratio, wrist circumference, neck circumference, and body fat percentage. So they may be applicable in various different circumstances, which may not be discussed further beyond this point as of now. So I'll straight away go to my first case. I'll expect participation from everyone. So it's a commonly encountered scenario in gynecology practice. A 16-year-old female presented with primarily oligoamenorrhea with cycles more than around 45, worsening hirsutism and significant weight gain over 2 years. So BMI of Ria is 35. The mother is concerned that there are about dark patches in the axilla, which is on the skin, that is acanthosis, and gynecologists have variously treated, as we all know, for PCOS with various hospitals, but they haven't controlled the weight or the cravings. So is it just lifestyle? So labs, if we go through the labs, TSH was normal, there was high testosterone, normal glucose, but fasting insulin was 35. So it was a clear-cut PCO with insulin resistance. Various OCPs have been offered previously, but they have not worked. So the reason being, insulin is a co-gonadotropin. So insulin has its action on the various adrenal and ovarian gonadotropins as well. So this is given by the two-hit hypothesis. So it's not just the LH driving the ovary. Hyperinsulinemia acts directly on the theca cells to stimulate the androgen production, and insulin suppresses the hepatic SHBG synthesis. So the lack of SHBG as well as the insulin-driven ovarian androgen production, they lead to increase in testosterone level. So they may not just be treated by giving simple OC pills. We need to address the core pathophysiology. So treat the insulin to fix the ovary. Metabolic correction using treatment for obesity, using either metformin, GLP-1s, restores the ovulation even before significant weight loss occurs. So this is a take-home message. So there is a strong association between a significant positive association. Overall increase of 1% in obesity prevalence corresponds to approximate 0.4% increase in PCOS, and there have been several studies that there is an increased risk of PCOS in women with obesity, with clear-cut demarcation in all these studies is the meta-analysis. So the mechanisms, as we all know, is hyperinsulinemia, which leads to insulin resistance. So it may cause type 2 diabetes. Along with it, there is a decrease in SHBG from the liver, which again drives the hyperandrogenism. Again, insulin leads to ovarian testosterone androgen production, which differs the ovarian leads to ovarian dysfunction. And the ovarian dysfunction combined leads to dysfunction. Simple. Treating the menstrual irregularities will not treat the PCOS. We have to address the primary weight gain, which is at the core of the metabolism. Once the insulin resistance will decrease, the patient symptoms will also increase. So next case is the 32-year-old female. The patient presented with primary infertility for 4 years. The patient has had regular menstrual cycles. So the patient is having BMI of 31 kg per meter square, which classifies as class 1 obesity. So she has undergone 2 cycles of IVF. Both times high quality euploid blastocysts were transferred, but the implantation failed. I'm very sure many of us practicing with IVF, they would have encountered such scenarios, and the anatomical evaluation is normal. There is no hysteroscopic defect. So everything looks perfect on paper. Why is the embryo not sticking? It's a very common clinical question. So the answer is there is presence of inflamed endometrium. It's just not the obstructive defect which is causing. So there is presence of visceral adiposity in obese patient, which leads to increased inflammatory cytokines, IL-6 and TNF-alpha. And this systemic inflammation leads to endometrial progesterone resistance. So the endometrial dysfunction driving out of obesity leads to difficulty in implantation. So even with high serum progesterone, the soil, that is endometrium, cannot properly decidualize the embryo. So this is a take home, that implantation failure in obesity is often non-obstructive. Anti-inflammatory strategies and weight optimization are critical for recurrent implantation failure. So there is clear-cut studies, so many studies have been there. I'll only go through take-home messages, that there is increasing association of infertility with in women with obesity, especially with class 1, class 2 and class 3 obesity. And the association is in terms of, as we just discussed, various defects. So there is a oocyte maturation defect, oligoanovulation, as well as the endometrial defects, which lead to ultimately culminate in terms of infertility in the patient. So there have been studies where there is effect of obesity on oocyte and embryo quality also in women undergoing in vitro fertilization. So one of these cohort studies where they showed that women with obesity had fewer normally fertilized oocytes and lower estradiol level compared to those with normal BMI. So it's not just the endometrial factor or anovulation. Even if the oocyte is recovered, that oocyte quality may also be faulty. It may not be capable to cause the fertility. Yeah. So is there any role of preconceptional weight loss? So many patients would come to you that, madam, I am obese, I am planning a conception. Will losing weight give me an advantage in my fertility? So the answer is yes. Pregnancy rates have been shown to be higher in various studies where women undergoing pre-consumption weight loss is there. So there is a food for thought for all our colleagues over here. Can we prevent infertility by managing obesity early in childhood? So still the data is very less. I'll just put one study over here. It was done in Australia. Well, almost 1,500 schoolgirls in the age group of 7 to 15 with 25-year follow-up. So it is shown that childhood obesity is associated with infertility in the reproductive. So when the girl reaches the reproductive age, even if the patient is having childhood obesity, they will have infertility. And the results demonstrated that childhood obesity before 12 years appears to increase the risk of female infertility in later half. So we may have something for young childhood girls also to prevent future infertility. Next case is Anjali is a 28-year-old female, G2P1, diagnosed with gestational diabetes mellitus at 24 weeks with fasting plasma glucose of 105. The BMI was 34. So this is a common scenario which we encounter. So the patient was very well referred to an endocrinologist. All things were continuing, and normally the glycemic control was very good. So despite decent glycemic control on diet, the 32-week scan showed large for gestational age fetus. So the natural concern from the parents or the family or the female, why is the baby growing so fast if the sugar is controlled? It's a natural question. So again, the answer for all such patients with GDM with normal glucose, but the patient is obese, is obesity. So the placenta obesity sets the placenta on fire. The placenta in obesity is not a passive barrier, it is an active inflammatory organ. Maternal obesity upregulates the NF-κ-beta and mTOR signaling pathways, and this inflammation increases the nutrient transport across the placenta. So the placenta is more able to more nutrients are able to cross the placenta, especially amino acids and glucose, which is independent of maternal blood glucose level. So despite good glycemic control, just because of presence of inflammation due to obesity, the patient will have large for gestational age fetus. So the clinical pulse for this discussion is we are treating two patients. The intrauterine environment programs the fetus's pancreatic set point, predisposing the offspring to obesity and diabetes in future. So just the presence of maternal obesity, is the baby at risk? Patients would ask. Yeah. So yes, the maternal obesity has short-term as well as long-term repercussions on the future of the child as well. There is increased risk of obesity, metabolic syndrome, and cardiovascular disease in the fetus later in the life. So there is a whole lot of conditions associated with maternal obesity, both for the mother as well as for the offspring. The mother may have future risk of cardiovascular disease and heart disease, as well as pregnancy-related GDM, gestational hypertension, preeclampsia, as well as other metabolic complication. And yes, the baby also does have repercussions in terms of various prematurity, macrosomia, neurodevelopmental disorder, and future risk of obesity and metabolic complications when the baby grows up. Next question. 5-year-old, she presented irregular cycles, pain, phobia, mid-11, and she asks, she visits the gynecology clinic and asks, I haven't changed my diet or exercise, but my waist is expanding. Doctor, what can be the reason? She feels her metabolism has broken. She is frustrated because her usual weight loss tricks aren't working. The blood pressure is on the higher side, 135/85. lipid profile shows elevated triglyceride. So the answer is the LPL switch. Estrogen normally inhibits the lipoprotein lipase in the visceral fat during the perimenopausal period. As estrogen drops, this brake is removed. Hence, there is rapid redistribution of the fat from gynecoid, that is subcutaneous fat, to the android or the visceral fat. And this visceral fat is the driving factor of all inflammatory markers of the entire inflammation related to obesity. And yes, the middle age spread is an endocrine event. This is the critical window for cardiovascular prevention, and visceral fat is a stronger predictor of CVD than the BMI itself. So yes, perimenopause directly has link with CV disease in the future. Just as we discussed, during the perimenopausal transition in obese female, there is increase in visceral fat, increase in LDL cholesterol, as well as future risk of metabolic syndrome, type 2 diabetes, hypertension, and cardiovascular risk. Similarly, in the perimenopausal period, most of you would have encountered there is obesity induced increase in prevalence up to 67% of stress urinary incontinence. So, another mechanical commonly encountered problem in perimenopausal female is directly linked to increase in BMI. The last case for today's discussion, Sunita is a 58-year-old female. She is purely postmenopausal, presented with postmenopausal bleeding. Her BMI is 40, that is class 3 obesity. Now, final ultrasound shows a thickened endometrium of about 12 millimeter, complex atypical hyperplasia. So, you could explain the endometrium is thickened, there is chance of some malignancy, and it is driven by hormones. So, the question is, my ovaries have stopped working years ago, I am postmenopausal. Where is the hormone coming from to feed this tumor? Naturally, it is an estrogen dependent tumor. Where would estrogen come from? So, the answer is peripheral aromatization. The adipose tissue is not inert. It overexpresses aromatase, converting adrenal androgens into estrone. And this is added upon by the insulin. Because of presence of insulin resistance, it promotes the cell proliferation and inhibits the apoptosis of the endometrial cells. So these two things club together, they lead to endometrial carcinoma. In this context, weight management in a postmenopausal female is directly similar to chemo prevention. It's just like prevention of cancer. Reducing adipose tissue cuts off the unopposed estrogen supply, which fuels the malignancy. So there is a lifelong cancer risk associated with obesity in women. Obesity is a major endocrine risk factor for all hormone-driven cancer. Of particular interest to all our gynec colleagues will be endometrial carcinoma. The risk is 2 to 4% higher. And the mechanism, as we discussed, is unopposed estrogen as well as insulin-induced tumor promotion. Other cancers which may have possible increased risk may be postmenopausal breast cancer as well as moderate association for ovarian cancer. So now we have discussed what are the spectrum of disorders and obese female may present with. So what are the benefits of reproduction in women? So it has long-term repercussions in terms of lower androgen level, lower risk of breast cancer, improved quality of life, prevention of PCOS, improved fertility, improved ovulation, improved stress urinary incontinence, lower risk of dysmenorrhea, lower risk of certain gynecological cancers, just as we discussed. So weight loss improves clinical features and long-term metabolic health in women with PCOS as well. So the primary line of treatment for PCOS, we should remember, is not just OSA pills, it is weight loss by various strategies. So it has got improvement in terms of decreased insulin resistance, decreased androgen level, reduction of hirsutism, acne, and the future risk of cardiovascular and disease and type 2 diabetes. Now, as we all know, the hot cake on today's discussion is semaglutide. Just before we started, Amita Madam were asking us questions regarding semaglutide. So, what is the role of semaglutide in perspective of gynecologists? Within next 3 or 4 slides, we'll discuss. Which Dr. Nilesh sir will be taking or in detail in the subsequent talk. But the message for my topic today is the currently available semaglutide dosing is 2.4 in India, but semaglutide 7.2 milligram has been shown up to 21% weight loss and almost more than 25% weight loss in 1 in 3 patients, and almost 90 patients achieve clinically significant weight loss. And the weight loss achieved using semaglutide was much compared to just lifestyle interventions. And it was sustained over a period of 4 years. And it also had other benefits in terms of glycemic benefit, HB1, it can reducing triglyceride. So it has got long-term cardiometabolic benefits in patients with obesity, especially PCOS in terms of gynecology. So now on that question, I'm very sure everyone would be, even Amita madam asked, could GLP-1 agonist PCOS? So we do not have direct study of PCOS patient, but one of the step 1 trial which was done for semaglutide, it does have exploratory analysis in terms of obesity and PCOS. So it was trial done with semaglutide against placebo compared to, in addition to lifestyle intervention, and almost 6.5% of those patients which were included in the step 1 trial had PCOS. And just taking the outcome of out of these 96 patients, we can say that group, the estimated change in the weight as well as waist circumference in patients with 2.4 milligram semaglutide was extremely good. Almost minus 15% weight loss was there, which was statistically very much significant. Also, reduction in waist circumference that we use to diagnose obesity have been very greatly improved, and this in turn would translate into outcome in terms of PCOS as well. So now in terms of gynecology, they have data from or the recommendation from the ISAR group, that is Indian Society of Assisted Reproduction. I am very sure most of you would be familiar with this group. It was published in 2024 in Indian Journal of OG, where they have included PCOS, infertility, menstrual disorder, and uterine fibroid as a part of obesity-related comorbidity as well. And treating obesity will have beneficial effect on all these comorbidities as well. So they have included semaglutide as a treatment for obesity in gynecology patients as well, in addition to diet and exercise, as well as they have considered as a recommendation for postpartum age management, anti-obesity treatment, as well as for patient with PCOS as well. So from Menarche, this guideline which they have published itself is named from Menarche to menopause. So they have given a very good recommendation for use in gynecology practice as well. Now, for simple, you would have in your mind whether using semaglutide will have any effect of the patient is taking oral contraceptive pills. So the answer is it does not affect the concentration of oral contraceptive pills. So it can be safely administered in addition to oral contraceptive pills. And what is the safety program profile with early pregnancy? Again, one of the common questions the gynecologist asks is, so we do have indirect data from various studies where there is no increased risk of congenital malformation by using GLP-1 analogs like semaglutide in women with type 2 diabetes. So this is the data driven out of type 2 diabetes. What has happened that due to obesity, due to certain reasons, the patients were not able to conceive. Once the weight started reduction, the patient achieved natural conception. So those babies were called Ozempic babies or semaglutide babies or Wegovy babies. Those babies, they have followed them up and they did not have any congenital malformation. However, direct pregnancy data, we are yet to have a full-fledged data. Yeah. So key takeaway message from my talk today is we have to address obesity early. It is a spectrum affecting the entire span of female, right from menarche to the reproductive years, pregnancy, perimenopause, and post-menopause, and life as well as intervention should be promoted in treatment of obesity. And one take-home message would be preconception weight loss. So if the patient is planning pregnancy, just losing 10% weight preconceptionally would have long-term beneficial to the female as well as to the child. And evidence-based pharmacotherapy like GLP-1 analogs, they have got very good numerous health benefits, 230 complications we discussed in the first slide itself, and would reduce cardiovascular and cardiometabolic risk in the future. So metabolic syndrome is a continuum. The metabolic dysfunction starts at menarche and compounds through the menopause as the female climbs up the ladder of the age. And adipose tissue is not just a mass, it is an active endocrine organ secreting hormones that disrupt every stage of reproduction, and hence recognizing the endocrine in gynecology allows for earlier intervention, better fertility outcomes, and prevention as well. So Gynec and Endo, as we say, Endo-Gynec Connect requires a close collaboration using various GLP-1s because the patient we are not allowing to conceive. So it is use contraception is on GLP-1 so that the patient may not have any adverse repercussions leading to pregnancy, and it has definitely oncologic benefit as well. So obesity is a chronic endocrine disease that acts as a multiplier for gynecologic pathology, and effective management requires shifting from treating the symptom to treating the metabolic root. So screen early, treat aggressively, and collaborate. That's it. Thank you.